Greetings and welcome to tonight's third forum sponsored by the Westchester Women's Advisory Board. My name is Margaret Fountain Coleman and I serve as the Vice Chair of the Westchester's Women's Advisory Board. And please take this moment right now to mute yourselves, as well as turning off your camera to ensure better Wi-Fi connection. The Westchester Women's Advisory Board is comprised of women representing every county legislative district of Westchester. This advisory board group makes recommendations to the county government about issues impacting the lives and livelihood of women of Westchester County. We are tasked in hearing the concerns of women in our districts, and tonight we further want to engage with you in hearing what issues are impacting Black women achieving health equity and navigating maternal health. This is the third of events that we've planned. The first event, Staying Sane During a Pandemic, was held in December. Issues Facing Immigrant Women was held in January. And all of these can be viewed online by logging onto westchester.gov website. The final event in this series will be held on March 9th, Women's Economic Equality. And we hope you will register and be part of the conversation. Please note as well to feel free to use the chat to check out the resources from the discussions that will be held tonight and the other forums we've presented as well. Before we begin, I want to pause and thank the incredible team that put this forum together. Ms. Pat Ryan, who's the chair, Ingrid Richards, Romania Levy, and the other committee members, you did a stellar job. On behalf of our board chair, Shannon Powell, we thank you ladies immensely. We also want to thank Robbie Schleff, Director of the Westchester Office for Women, for her guidance and support. Special thank yous to Stephanie Basilin and the County Executive Office and Communications staff for being so supportive. And we would like to thank also the Westchester Women's Agenda for partnering in this endeavor. And now we will hear from the Westchester County Executive, Mr. George Latimer. Can we greet him?
Thank you very much, Margaret. I appreciate being with you tonight, and I'll be extremely brief because the substance of this topic tonight is really why everybody is taking the time beyond this. We're on many different Zoom meetings of various different importance, but achieving health equity for women in this society, and particularly women of color, couldn't be more important. And what COVID has exposed to everybody is what those inequities are. When we talk about access to testing and access to vaccination, it's clear that we are not reaching all of our society as is necessary. And what we have to do, those of us in government, is simply to do a better job. But to do that, we need to understand what it is that today's reality is, and then how to fix it. And the best people that can do that are those that are most affected by it. It's not us old white men to do that. It really comes out of the experience of being a woman, being an experience of a person of color, to help us go in the right path. What I commit to you is that I will be an ally for the solutions, and that women will lead and smart men will know how to follow. And out of that process, we'll have better results, and we hope to see it soon, and we hope to see it for the rest of time. Margaret, thank you for the opportunity to greet you all. Thank you for being here tonight. Forward we go together.
Thank you so much. Thank you so much. Before I acknowledge other elected officials who have joined us, I want to read a statement from our U.S. Senator Kirsten Gillibrand. The maternal mortality crisis continues to have a disproportionate impact on Black women who are up to 3 times more likely to die from a pregnancy-related complication. These women are always the first ones to show up for their communities, and yet they are too often forgotten or silenced in the conversation on maternal health. That's why I'm proud to have introduced the Moms Act, which would provide resources to states and hospitals to implement best practices to prevent maternal mortality and morbidity, and to be a co-sponsor of the Black Maternal Health Omnibus Act introduced by my colleagues, Senator Booker and Representatives Underwood and Adams. These critical bills ensure that Black women's voices are heard and will go a long way to improving the maternal health outcomes of women in Westchester and across the country. I am committed to lifting up the voices of Black mothers in Washington so that we can finally put an end to racial and ethnic disparities in maternal health outcomes. And we so appreciate the senator's words. We would like to thank our Westchester officials as well as our New York State legislators who have joined us this evening. We're glad to have on the Zoom meeting and call State Senator Shelley Mayer, County Legislator Ruth Walter, County Legislator Nancy Barr. We're also glad to have with us Jan Fisher, Director of Not-for-Profit Westchester, Michael Orth, Commissioner of County Department of Mental Health, and Colleen Braithwaite, who is the chair of the Westchester Women's Agenda. Thank you so much for joining us tonight. And as we get other electeds here, I know that we will recognize you appropriately. Now, tonight, I am honored to introduce a community partner who is championing the work for Black girls and women here in Westchester County. She is vested in the work of equity, justice, and empowerment for women. Ms. Cheryl Brannon is founder of Sister to Sister International, and she's the convener of the Black Women Girl Child Initiative and president of the Brannon Solutions Group, a multifaceted consulting firm. She is committed to the empowerment of Black women and girls, a seasoned professional, leader, and trailblazer in political, civic, corporate, and international arenas. So would you please join me in welcoming Ms. Cheryl Brannon.
Thank you so very much, Reverend Margaret, for that wonderful introduction. I so appreciate it. And I'm just delighted to be here tonight with so many folks to talk about a very important topic. I wanted to first just quickly acknowledge some people who have been very important to our work, including, of course, County Executive George Latimer and Deputy County Executive Ken Jenkins. And then, of course, the Westchester County Board of Legislators and our champions, the Honorable Terry Clements, Honorable Chris Johnson, the Honorable Ruth Walters. And then, of course, we have the Westchester County Youth Bureau and Dr. Damia Harris Madden. When we look at the Westchester County Office for Women, the Executive Director, of course, Robbie Schlaf, Westchester Women's Advisory Board, Dr. Pat Wren, leader. Then, of course, the STSI Subcommittee Co-Chair, Nubia Martin, who you will hear from later this evening, and our steering committee member, Mecca Mitchell. So you can see we are in great company. And what I'd like to do now is dive right in and give you some quick background on Sister to Sister International and our Black Women Girl Child Initiative. We started doing this work back in 2015 with the Obama White House Council on Women. And then in 2019, we produced the Still I Rise snapshot report on Black women and girls in Westchester County. And there are 4 pillars that we focus on, including teenage pregnancy prevention, maternal health and healthy lifestyles, entrepreneurship, STEM and STEAM, and of course the juvenile justice system. So we have been working with all of our community stakeholders, and these are some of the logos in front of you, working for over a year as a result of the outputs from that report to develop strategies to bring forth for action this year. Now, when we look at this evening's theme, Achieving Health Equity, Navigating Black Maternal Care and Other Health Disparities, it really is going to take a village to increase and to certainly enhance health for Black women. Why? Why, I ask, why? Why are Black women 3 to 4 times more likely to die of pregnancy related to conditions than their white counterparts? Whether it's hypertension or diabetes, why Black women? And why are Black women perceived as being able to endure more pain than our white counterparts? Well, our research outlines that racism is all over our healthcare system, and I'm sure that's not something new for you. Black women are neglected across the spectrum, and we can't just look at maternal health alone. It's not a standalone. We really have to look at the social determinants of health. We need to look at race. We need to look at ethnicity. We need to look at where people live. Where do they work? Where are they housed? What education levels do they have? And socioeconomic levels. And not only do we need to look at it, we need to make sure we have the data so that we can disaggregate it and make changes where necessary based on what the data tells us. We really need a holistic approach, and it really is going to take a village, it absolutely will, to address these factors. Well, I can tell you, despite all of that, ladies and gentlemen, brothers and sisters on the call, I am inspired. I am inspired by the Biden-Harris administration. I am inspired by Kamala Harris. I'm inspired by their willingness to take on an equity agenda, a health equity agenda, and the fact that Vice President Kamala Harris has also been a staunch supporter of maternal health. So they're doing their thing on the national level, but guess what? We have to make sure we're doing our thing locally in terms of implementing actions. So what we're doing as part of the Black Women Girl Child Initiative, we actually have a press conference and various campaign launches that we'll be announcing on February 18th. Birth to the Earth and Earth Grounds, which is Nubia Martin's organization, will have a ribbon cutting. And she has a marvelous space in Getty Square that will provide holistic healing, access to resources, birthing workshops, you name it. We're very excited about doing a ribbon cutting on that space and continuing to have women, of course, take advantage of it. And if that were not enough, we have a preeclampsia literacy and prevention campaign based on maternal high blood pressure. And we're going to focus on what it is, the signs, how to take blood pressure accurately, and when there is a need for follow-up with one's provider team. So we're going to be incorporating all of that into Birth to the Earth, as well as working with other community partners like Lower Hudson Valley Perinatal Network, etc. But then we want to look at women's health across the spectrum. So we have a campaign, Sisters Beating the Odds and Claiming Wellness. It's a health literacy campaign, and it encourages women to know their stats, to go get those health screenings, and to know what their current state is so that, again, they can take the appropriate action. And it gives them a chance to win prizes, etc. So those are the two campaigns that we will be announcing along with the ribbon cutting on February 18th. We're also working closely with St. John's Riverside Hospital. I see some of our friends are on the call. We see Ron Cordy, the president, in the middle, and his team, and our Black Women Girl Child team. And our goal is to make St. John's Riverside Hospital a standards of care, a best practice for improving birth outcomes for Black women in Westchester, to make it a pilot that we can share throughout the county. Then we also put together a calendar of our collective impact activities and events. Of course, we just talked about February 18th. We've got others that you can check on our website, but I wanted to point out the maternal reproductive health pillar on March 9th. Planned Parenthood has an event in Albany. And then our friends at Westchester Women's Agenda have a reproductive justice, a conversation with Loretta Ross, a noted advocate, author, and leader, on April 13th. So please go to the Sister to Sister International website to get all of the information that you might need, and certainly feel free to join us on this journey. So I hope you've enjoyed that helicopters overview. And certainly I'm delighted to be here, and thank you all for the opportunity. And now it is my absolute great pleasure to introduce you to none other than Dr. Juliet M. Nevins. Dr. Nevins is a clinical solutions medical director responsible for the New York, New Jersey region at Aetna, a CVS health company. She is also an attending physician in obstetrics and gynecology at Montefiore St. Luke's Cornwall Hospital. And she's the founder of, get this, belowthebellybutton.com. It's an online educational source about women's health. Juliet is an alumna of Vassar College. She also earned a master's in public administration and health policy from New York University. She continued her studies at the University of Virginia School of Medicine, where she earned her medical degree. In the role of medical director, she serves as the clinical lead for the collaborative efforts between physicians and hospitals and the Aetna Health Management Team. Her passion for consumer health education and wellness has been consistent and has colored her roles as both a physician and a clinician executive. She fervently believes that health education is a critical tool that can change behavior, improve the health of individuals, and facilitate intact communities. Ladies and gentlemen, it's my pleasure to give to you none other than Dr. Juliet Nevins, who will serve as the moderator for tonight's great panel.
Ladies and gentlemen, thank you so much for taking the time to be with us this evening to have this very important conversation around navigating Black maternal health care and other disparities. I want to begin by thanking the Westchester Women's Advisory Board for collating their efforts and bringing us all here this evening. I'm going to start with a statement. 700 women die each year. We've heard the stats. Black women are 2 to 3 times more likely to die than their counterparts. And if the woman is older than 30, that number goes up to 4 times. There are several issues going on with this. One, Black women, because of the socioeconomic determinants that Cheryl just delineated for you, go into healthcare systems burdened by pre-existing or chronic illnesses. And then certainly you have systemic racism that colors the experience of these women on the individual, patient, physician level, and also with respect to the systems. So we have 2 fantastic panelists here who are going to help us dive into these topics. I'm going to start by introducing you to Mecca Santana Mitchell, Esquire. She is the Senior Vice President of Diversity, Inclusion, and Community Engagement for the Westchester Medical Center, a 10-hospital system in the Hudson Valley, which most of you are all too familiar with. She is responsible for building and leveraging relationships with external stakeholders to explore innovative partnerships that create sustainable health and promote community vitality. Mrs. Mitchell also ensures that all internal organizational policies and procedures are aligned with diversity, inclusion, and equity best practices. Prior to this position, Mrs. Mitchell served as the Chief Diversity Officer for the state of New York, appointed by Governor Andrew Cuomo. She was responsible for the creation and implementation of recruitment and retention initiatives designed to promote workforce diversity and inclusion, while also leading statewide initiatives to increase minority and women-owned business opportunities. Prior to joining the Cuomo administration, Mrs. Mitchell was the Executive Director of Equal Employment Opportunity and Diversity Management of the New York City Department of Education. She began her legal career as an assistant district attorney in the Manhattan District Attorney's Office, where she prosecuted assorted criminal matters as a member of the Trial Division Sex Crimes and Domestic Violence Units. Mrs. Mitchell holds certifications from Cornell University's School of Industrial and Labor Relations in Diversity Management and Equal Employment Opportunity Studies. Mrs. Mitchell graduated from Hofstra University School of Law in June of 2000 and is a graduate of the State University of New York at Albany, where she double majored in criminal justice and political science. She brings with her all of that and a wealth of knowledge. I'm going to move on to another fabulous panelist, and I bring to you Nubia Earth Martin. Nubia is a community birth worker, traditional midwife, and founder and president of Birth from the Earth Incorporated. This is a nonprofit organization steeped in education and empowerment, providing a variety of health and wellness services. Nubia holds a master's degree in midwifery and a bachelor's degree in sociology. She is a childbirth educator, provides birth and postpartum support, and offers lactation consulting. Nubia Martin sits on the board for Chocolate Milk Cafe National, the Black Coalition for Safe Motherhood, and the Hudson Valley Birth Network. Nubia is dedicated to improving birth outcomes for women of color and toppling maternal mortality and morbidity rate disparities. The legacy and lineage of the grand midwives run deep through Nubia Martin. She sees midwifery not as a profession, but as a way of life and a rite of passage. Thank you both for being here with us this evening and for looking so gorgeous. So we're going to dive right into our questions, ladies. We have basically two pillars, two themes, if you will, and our questions are going to necessarily sort of cover and embody the things that we want to talk about. So Nubia, I'm going to start with you because you are in the Westchester community. You can certainly give us, an interpretation of your bird's eye view, if you will, in terms of what you're seeing. One of my biggest concerns around maternity health care is preconception health. And as Cheryl talked about with respect to her work, health literacy and an understanding of how important it is to go into pregnancy in the best possible physical and mental state. So, I think we know all the stats in terms of food deserts, the link between your zip code and your potential risk of having an untoward outcome. So Nubia, what are some of the workarounds that we can suggest to facilitate better baseline nutrition, for example? And within that topic, I want to talk about weight. We want to sort of improve the status of women in this space prior to pregnancy. What are you seeing? What are you recommending? Can you tell us what you're seeing and what your thoughts are around this topic?
Sure. So just really grateful to be here in this space, first and foremost. When we talk about preconception health, that's one of the main things that we focus on at Birth from the Earth, because we know that certain pre-existing conditions can complicate a pregnancy. And of course, we want to promote healthy, low-risk pregnancies. So we're talking about things like chronic diabetes, we're talking and can you hear me? Okay. I think it auto muted me, but I can't hear you guys though. Hold on. Okay. Can you hear me?
You're fine.
Yes, I can hear you.
Okay. Okay. So we're talking more about prevention rather than having to get behind a condition once you're already pregnant and now you're already experiencing something high risk. And we're also talking about optimal nutrition and herbal nourishment so that we're not just throwing a pill at these, different conditions, because that's not actually treating the condition. It's just masking it or managing it. And there are many people who, once they're pregnant, they don't want to be on prescribed medication anymore. So we want to talk to them about how these conditions actually manifest and how we can address them. And we also want to normalize healthy lifestyles. So thinking about, the choices in foods, brown rice versus, white rice, healthy fats, adequate amounts of protein and calcium and potassium in our diets. And then not just saying, eat 2 ounces of this or 4 cups of this, but putting it in actual real life, proportions, 2 slices of avocado, a handful of cashews. And in terms of, healthy weight and how that pertains to women of color, I think the BMI scale that we use is not really created in mind for women of color and our body types. According to that scale, I'm obese. So we need to really think about how we have those conversations and promote healthy activities, dancing, Zumba, balancing out our food intake and our actual physical activity. I think those things are important, and not body shaming somebody, but setting healthy goals for where would you like to be. And if people understand the things that can complicate a pregnancy before they actually conceive, they're going to be more apt to get on top of those things. So they have to know how these conditions manifest and the things that they can do to combat them. Regarding food deserts, that's a real phenomenon, but we can also create community gardens. So we have a community garden that we created specifically for Chocolate Milk Cafe. It will now expand to be part of Earth Grounds. There are food co-ops, there are farmers markets, and we also do cooking demos to show people how to incorporate these foods that they get from the farmers market, so they don't just sit and go bad in your refrigerator, but you can actually incorporate them into your daily lifestyle. So it's really what I always say, an SOS situation. We have to save ourselves, and we do that when we're well equipped with factual information, knowledge, and resources.
I thank you very much. I want to go back to 2 things. First,
Mhm.
I want to make a comment around the BMI. So I actually attended a fantastic seminar on Sunday around heart health. And one of the things that was brought to bear during that conversation was it's not necessarily a function of the BMI alone, but the amount of fat that is around your visceral organs, right?
Yeah.
So we can sort of think about it even on that level with respect to your muscle mass and your weight distribution. So we can
Right.
go even further when we're trying to explain and teach women that it's not necessarily about the way your body is configured or shaped. It's really about the fat deposition and where that fat deposition risk sits and how it increases your risk.
Yeah.
I want to press you a little bit because
Okay.
we here are in the know, right? And then there are others who are here to learn. So what I'd like to understand is what is the perception of women in the community around, to use your phrase, normalizing healthy lifestyle. When they come to you, where are they? I mean, what are you finding? What are you seeing?
Right. So I see a wide spectrum. Some people come with, they'll say, well, I'm just always anemic. I've been told that. I'm like, well, you don't have to be anemic. Here's how we can actually correct it. But that has been normalized for them. You're anemic, and that's something that they have kind of claimed and not really thought about how they actually correct that. They don't want to take the iron pills because they cause constipation. But what we do is then focus on what this means if you stay chronically anemic, right? How it impacts your energy levels. We talk to them about, how are you feeling on a day to day? We talk about blood loss with their, menstrual cycles and how that can further impact anemia. And then we talk about the importance of correcting that, because that can complicate a pregnancy in terms of where you choose to give birth, the amount of blood that you might lose, and all of these things. So it's really about putting it into a conversation that they can understand why this is important for their health, as opposed to just saying, here's a script, take this, and then they don't really understand the correlation with why this is pertinent to their actual health. I wanted to jump to something that you said, you brought up heart health.
Mhm.
And I think that's really important because that seems to be what has taken precedence over why Black women are dying in maternal health. Before we had all these other myths that we were dispelling. And now that those have been dispelled, it's more heart health. And if Black women would just get their heart health together, we wouldn't be in this space. And, I implore people to think about, what does it mean when someone in their 20s or 30s has, a cardiomyopathy or congestive heart failure? How do these things manifest in such a short, amount of time, considering they're only in their 20s or 30s, and that's a short lifespan so far, right? And I want people to think about the impact of our heart chakras and all the atrocities and traumas the Black women have faced through, generational, enslavement, and how we have not had a space to properly address that or heal from that. And that does have an impact on our heart health. So yes, it is, positive cardio and eating well and talking about, fat composition, but it's also addressing the space that we need to have places for deep healing when we're talking about epigenetic, generational trauma and cellular DNA that is not going to change overnight because we've been impacted greatly by these things.
And I would agree with that. So if you look at the list, right, in terms of what impacts your heart, it's stop smoking, it's control your weight, it's control your waist circumference, specifically,
Right.
going back to my comment about the visceral fat. It's getting exercise and not being, sedentary. And it's also stress management, right? That is on there as well. And in terms of Black women who are particularly at risk because they're unaware, it is the age group of between, 35 and 44. So you can imagine that there is a cumulative effect in terms of you're now presenting in pregnancy when your baseline heart health is not optimal. So I want to thank you for driving this point home in terms of the need for preconception education around why certain health habits are critical, not just for your own longevity, but certainly if you want to have a healthy pregnancy. What you're doing, certainly the work of Cheryl's organizations, these are the kind of resources that we need more of to give women access to this type of information, in addition to discussions like the one we're having this evening. So I want to thank you for that. I'm going to pivot just a little bit. I want to talk about the topic of empowerment. That's a very sort of, intangible discussion, if you will. We don't necessarily have statistics around that, but for many women of color, the experience with the healthcare system is not unlike the experience with other institutions. This is just an extension of, how we live. Always bracing against micro and macro aggressions. We know that the onus should not be on the patient, however, to guard against racism. However, patients should be empowered to ask questions and expect certain levels of care. So, big question for you, Nubia. How do we engender a sense of empowerment? How do we teach women that it's okay to, ask questions and to probe and make sure you are satisfied, and that there is sharing of the decision in terms of what's happening with your body? How do we do that from your perspective?
Right. So, empowerment and being able to find your voice, being able to speak up for yourself and know how to advocate for yourself. And also anyone who has a hand in your prenatal care, that they know how to also speak up and advocate for you if you're unable to, is at the cornerstone, what we do. And in my bio, you mentioned that I am on the board of the Black Coalition for Safe Motherhood. And we collectively put together a curriculum called ACT, which is an acronym. It stands for Ask Questions, and so you understand the answers. Claim your space, both physically and mentally. Trust your body and tell your story. And we put together this curriculum in a way that, healthcare consumers, birth workers, anybody, family members, friends, have a way to practice how to have a dialogue with your provider, right? Because people get white coat syndrome. They have all the questions they want to ask, and then they get into the office and no eye contact is being made, or they're rushed in and rushed out, and they leave not having a full understanding of what their healthcare plan is, and not getting their answers, to the questions. And if you're not getting your questions answered, it's really difficult to make an informed decision if you don't know the risks and benefits of something that is being presented to you. So we practice different scenarios. We practice how to use those not only at prenatal visits, but also in the labor and delivery room, if appropriate. And I think understanding that this is your space to claim, right? So you might have been in the waiting area for 45 minutes. Your visit might be 15 minutes. You want to make sure that in those 15 minutes, you're getting, your concerns met. You're finding your voice, you're asking questions, and that you leave feeling more empowered than you did before you came in. And if you don't, then seeking out other providers who are going to be able to give you that undivided attention and make you feel safe within the care that you're receiving. And you touched on, shared decision making. That's important. I tell people all the time, this is your baby, your body, your birth. So you want to be an integral part of that care that you're receiving. And the onus should not be on us to make sure that a provider is doing their due diligence. But until we get to a space that is the norm, we do need to know how to speak up and advocate for ourselves, because it often does mean a difference between life and death, especially for women of color.
Great. So, what we're really talking about is racism. And I'd like, Mecca, you're nodding your head. And before you, I'd like for you to sort of add to this conversation. I know you're coming from more of a systemic, potentially, legal arena, but I think what you have to say here would be invaluable. I do want to just pause to ask everyone to mute, please, so that we can have a nice, clean recording, and so that there's no interruption in terms of, the technology that's going on here. Mecca, can you chime in on this topic of empowerment, and sort of how does one position oneself in institutions where racism is necessarily endemic? What points do you have, for the audience, for us? What can you teach us?
Thank you so much. So happy to participate on this panel. Before I talk about the institutional part, I want to just back up a little bit and share a personal story I have that relates to this topic, and it goes to the heart of that empowerment that we all understand is so important. And I shared this during our briefing call, that 20 years ago, when I had my first pregnancy with my son, and at the time did not have any family support. My family didn't live here. I was living with my ex-husband in the Bronx, not a particularly great neighborhood. We didn't have tons of resources, working for the government, working for the state of New York, just went to my local healthcare provider, didn't do a lot of research, and ended up having a tremendously difficult pregnancy with a doctor who did not listen to my concerns, who was very rushed. Every visit was very rushed, who after about my 6 month of pregnancy, when I was telling him that I wasn't feeling the baby move, completely dismissed my concerns over and over again. And to the point where I went for my last visit with this doctor. He wanted to rush me in and out. It was a Friday. He was going on vacation. And I raised the concern again about not having felt the baby move now in over a month. Mm-hmm. And he was it was over a month. I'll never forget it. And what I got was, oh, your baby's just too large. It's going to be 9 or 10 pounds. Your concerns are ridiculous. I'll see you back here in 2 weeks.
And did he use that word, ridiculous?
Ridiculous. Your concerns are ridiculous. You're a new mom. I'll see you back here in 2 weeks. And I recall the feeling when he walked out of the office, that feeling of utter desperation and hopelessness, because I knew something was wrong. I knew it. And I ended up calling him back into the office and telling him, listen, you're going to have to do something. You're going to have to send me somewhere. And the only thing that caused him to send me ultimately to Einstein Hospital was the fact that I said, I want to see you put in the file that I've been complaining about this. And I want you to remember what I do for a living. Mm-hmm. And he kind of paused and he said, well, what is it you do again? I said, I'm an attorney. Mm-hmm. And he got really, you could tell he was kind of taken aback. And he said, you know what? I'm going to send you to Einstein Hospital. They're going to do a sonogram. It's a complete waste of your time. I'll see you back here in 2 weeks. And immediately upon getting to Einstein and getting my sonogram done, I knew something was wrong because the woman wasn't talking. She wasn't saying anything to me. And she put the device down and she said, I'll be right back. Came back, 2 doctors who said, the reason you're not feeling your baby move isn't because your baby's outgrown the space. They said, you have almost no amniotic fluid. Mm-hmm. Your child isn't floating in anything. Mm-hmm. And at that time, I still wasn't overtly concerned. I said, okay, so I'll share that information with my doctor. I'll be back in 2 weeks. He said, you don't understand. We're prepping an operating room for you right now. We've got
that's very serious. Yeah. Mm-hmm.
We got to get this child out. Mm-hmm. And so in that, less than an hour later, I'm having an emergency cesarean. And I recall the words of the doctor, who wasn't my doctor. He didn't even have time to get to the hospital. The words of the doctor who delivered my son. He turned to the nurse and said, "Is this a full-term baby?" Because my son was a little over 4 pounds. I mean, his skin was hanging off. He had not been being nourished. And it was such a traumatic experience for me. And 2 days later, when I was still recovering, I asked the doctor, I said, my doctor told me to come back in 2 weeks for my follow-up visit. I said, will my son have made it another 2 weeks?
No.
I can't guarantee your son would have made it another 2 days.
Right.
And
Yeah.
I say all this to say, I was a practicing attorney. I was used to arguing for a living. I was used to being an advocate for a living. And yet in those moments, you feel powerless. The power dynamic was so one-sided. I was so ill-prepared to ask those questions. I didn't feel like I had any power in that dynamic. And as a result, it almost cost me my son. And so I think that that point can't be understated, because again, as I look back, the rush treatment, I believe the doctor looked at me like any black or brown face that was in there. I wasn't wearing my wedding ring at the time. And so he thought another unwed mother. And so my voice was not the voice he felt was important to listen to. And so again, I think that part of it becomes so important, that need to empower and the trauma that it caused me. So going into my subsequent pregnancy years later with my daughter, 5 years later, I had a Black female OBGYN, and I was very upfront with her about the trauma that I had experienced and explaining to her, I'm going to be your partner in this process, whether you like it or not. Fortunately, that worked for her, and we're still close to this day, but I had to be an active partner. I had to know what was going on. I had to feel like my concerns were being addressed, so that I had a healthy pregnancy. So I was not traumatized by what I experienced. And again, if that was my experience, you can imagine the experience of other people out there with language barriers, other people out there with education barriers. This is a very real issue, and it's an issue that's costing lives, because here's the reality. You can't apologize to me after you cost my son. There's no apology for that. There's no lawsuit that fixes that. So that issue of empowerment is something I've always been a big proponent on. And the reality is, empowerment in healthcare empowers you in other areas of your life. When you're empowered to speak up to that doctor, to ask those questions, you're empowered when you go into your job and you think you're not being paid adequately. You're empowered when you go to talk to your son's teacher about his grades and his assessment. It empowers you in all of these other areas that, in particularly women of color, need to be empowered. And so that's why that issue is so critically important. And that's why we do a lot of work around, again, educating, normalizing, partnership. We talk about the fact that, our patients are our partners in this process, and we mean that when we say it. And so we do a tremendous amount of training and education and cultural intelligence raising to make sure that our folks in our hospital know that and understand that.
So I thank you for sharing that story. I am so happy that you're here and that your son is healthy, and that you both made it. You were lucky, and I say that as an OBGYN, so that you're what we call a near miss, if you will. But you touched on something that I want to go back to, and that's the preamble. One of the questions that came in over the chat has to do with mental health. There are a lot of stressors that Black women, Black people have to deal with even prior to, getting pregnant. What are we going to do about that? I mean, and I know that question is that big, but, Nubia, I'm going to start with you in terms of, what kind of resources do we have out there, sort of community circles to vent and decompress and talk about this. Institutional resources, Mecca, that you may be aware of, such that you can alert and inform the audience. So Nubia, we'll start with you in terms of the mental health piece, and how that contributes necessarily to the outcomes that we're talking about this evening.
Yeah, well, you touched on the fact of, stress and the stressors that we deal with. And, for women of color, just showing up as a woman of color in this country is a stress in and of itself, right? So, and then you add on top of that, perhaps they are the head of household. Maybe they're the main breadwinner, the primary care provider. Maybe their job, job insecurity is an issue. You have all of these stress factors that you're already contending with. And then you might add on top of that a pregnancy, a provider that's not really listening to you, care that you're not certain about. And the way in which stress impacts Black women is different. The way it impacts our babies in utero is different. So when you're talking about starting out from a point with an allostatic load of all these stress hormones, cortisol, adrenaline, constantly streaming through your system, that in turn results in preterm labor for us at a higher rate, preterm babies, premature babies, stillborns, right? Because there's no way, there's no break from that, so people might get a break from their work or take a vacation and they're not having to deal with their boss, or maybe they have saved up enough money where they don't feel that they're stressed by finances. But we don't get to wake up every day and say, I want to take a break from being a Black woman in this world. And if we're being real and talking about the fact that this country was created steeped in, bred in racism and racist thought, laws, policies, social constructs, notions, themes, we have to be willing to address that head on. We have to be willing to topple those things. And we have to be willing to also build back up from a place of cultural sensitivity, competence, and really, just destroying all of these social man-made constructs that place inferior and superior ideas. So in terms of how do we deal with stress, that's one of the first things I ask if somebody comes to me. What are the stressors in your life? Because I want to kind of mitigate, how can we eliminate some of those? And one of the biggest ways is just centering and listening to somebody. And that's really the midwifery model of care, that each person gets unique care from their midwife because you're individualizing care based on their specific needs. So there's not one cookie cutter approach to prenatal care. And a lot of the visit, while yes, we do all the same clinical things, the majority of the visit, like 45 minutes or so, is actually listening to this person. What are their concerns? Maybe they had a previous, birth experience that was traumatic. How do we get past that? How do we get to a space where that's not a fear in the back of their mind? How do we assure them that they're in a good, safe space, getting adequate care, and that they do get to be an integral part of their own, pregnancy journey, and that they get to choose where they birth, how they birth, and with whom? That's a big stress load off. I promote home birth for people who are experiencing healthy low risk pregnancies because you're in your own environment. So that takes a huge stressor, out of the situation in terms of being able to create a space that is uniquely yours. What do you want it to smell like? What do you want it to look like? Who do you want to be there? So those are the different things. And if somebody is wanting to birth, in a hospital, we want to make sure that they get to be in a space where they're also feeling cared for. We want to make sure that the hospitals are doing their due diligence. If they want to birth in a birthing center, we want to provide them a list of all the different birthing centers in their area, what insurance they take. So we're arming them with factual information so that they can make informed decisions. And that is not a stress that they're dealing with.
I think I want to touch on two things. In terms of stress, I think the first step to alleviating it is bringing it to the attention of the woman that her life is, stressful. And I think once the patient acknowledges, wow, that I am stressed, and they're more mindful of what they're doing and how they're interacting with the world, whether or not they can change or control the circumstances. But I think just being more mindful of its impact on their lives and subsequently their pregnancy, I think is of import. I think in terms of making changes, first one has to understand what the initial problem is. So education back again, in terms of being literate, in terms of how the mind and the body affects, your lifespan, not just, the slice, the 9 months that you're bringing a human being into the world. Often you have women who are potentially at higher risk because of the socioeconomic determinants, because of these underlying risk factors, and they live in hospitals or in neighborhoods where hospitals are not necessarily optimally resourced, right? And that creates a mismatch, right? You have people who are particularly burdened by illness, pre-existing disease, and they're going to hospitals and are not able to necessarily care for them.
Right.
So this brings into the question of empowerment, access. And Mecca, I'm going to turn to you to begin with this question. You know, what do we do with that? You know, I mean, what do we do with hospitals that are not necessarily equipped to take care of the acuity or in terms of the disease burden in their community? I know I'm throwing a big question at you. I know, I'm a tough one. But I just wanted to put it out there so that we understand what some of the issues are.
Well, I think I'll combine this with an answer I was going to give to your previous question, which is from the standpoint of the healthcare systems and hospitals, how are we addressing some of what you're talking about? How are we addressing some of these challenges? How are we ensuring that the requisite empowerment of vulnerable communities happens? Well, one of the ways you do that is by ensuring you have a workforce and clinicians who reflect the communities that you serve. That is directly tied to the issue of health equity. You want people in decision-making positions, and I mean everything from administration to the actual clinicians who are meting out the care, to actually have perspectives that run the gamut from those who they're treating. You can't build trust with a community unless you're able to share some common humanity, unless you've walked in the shoes of some of your community members or have, again, some cultural intelligence about community members. So I am not a member of the LGBT community, but I have immersed myself for years in being an advocate for that community, particularly when it comes to healthcare. And so those issues are always top of mind for me. And so I think that becomes part of the training and some of the resources that healthcare organizations have to invest in making sure that their workforce has that cultural intelligence, is trying to meet head on and address the unconscious bias that is rampant in healthcare. And anyone who says it's not, anyone who says they're not biased, it's just a foolish thing to say at this point. We all are biased. We all have those biases. The problem is in healthcare, those biases, again, have deadly consequences.
Right.
So we understand I get treated very differently when I walk into an urgent care, when I'm dressed like I am right now, or when I have my baseball cap and my yoga pants on. That's reality. When I was married and my last name was Santana, I recall sitting in a doctor's waiting room for almost over an hour, just waiting, wondering why people were being called and I wasn't. Finally, when I went up to ask, someone said, well, we were waiting for the interpreter. Well,
oh my goodness.
The English, they saw the name.
We laugh about this now, but it's not funny.
But that's the reality. They saw the name and they made an assumption. They made an assumption about the totality of who I was in that moment. And that happens all the time. And so making sure that our doctors practice more narrative kind of medicine. Let me tell me your story. Let me sit for that extra 5 minutes with you and you tell me your story. Tell me about your background. Tell me about how you were raised in the Caribbean. So then I understand about your food and your nutrition and your culture. So when I tell you stop eating those salty, fatty foods, I know how that's going to land with you, how that's going to land with you. And I'm being smart and I'm being intelligent about who you are when it comes to the information I'm giving you. So I think there has to be a real investment on the part of systems to be willing to change their systems, to understand that the system has to change to accommodate the diverse, the vulnerable, the underserved populations out there who don't always look like us, walk like us, talk like us, but they are the most in need. And if you went into this profession to be of service and in service to that community, then you have to know everything about that community, where they go to church, what their culture is, what their history is, what their fears are, what their goals are. And unfortunately, that doesn't happen as often as it should. So I think that's some of that investment we're talking about. And then I think if hospitals are able to do more of that, they get to the heart of what you said. How do you touch and how do you serve every community? You do it in partnership. We know we can't keep communities healthy within the four walls of our hospital. We can't. So what do? We partner with community-based organizations. We partner with Cheryl and Sister to Sister. We partner with LGBT orgs and the churches. We partner with those other trusted community external stakeholders who we say, let's do this together, because they'll trust you. For behavioral health issues, you know, before people come to seek professional help, where's one of the first places they go? To their pastor, their rabbi, their imam. So let's partner with those heads of those faith organizations to talk about spiritual health and clinical health and understanding the difference. So I think so much of, again, reaching every community, you do it in partnership. You do it by being humble and understanding that we are not the end all be all as a profession. You know, we are faulty like everyone else, and acknowledging that, but acknowledging that we have to do better. Again, the onus is not on the patient. The onus is not on the underserved community. The onus is on us. What are we prepared to change structurally to make sure we're doing what we're supposed to do?
And so the answer is not necessarily leaving your community, because there's value there, especially if the employees are diverse and can connect with that community. And to, you know, based on what your remarks are, we can supplement and we can optimize the care right, you know, right where you live. We can bring care to the patient as opposed to asking them to leave. So we're gonna stay on this topic, okay? Systemic racism is just that. Policies and procedures that are built into the system such that one or more groups of people benefit while others remain at a disadvantage. It is also a function of a collective attitude towards one or more groups of people, prejudice, that are then executed, racism, such that groups of people are subsequently affected. So, why is cultural sensitivity training needed? Our previous president said that was absurd. Get rid of that, right? Does it work, Nneka? Is the goal to change how doctors and nurses think, or just how they behave?
I think the ultimate goal is to do both, but I'll start talking about conduct, and I'll use what was common years ago, not as much now. But when it came to treating, I'll give LGBT patients as an example. You might have doctors who would have said, you know what? I don't want to treat this patient because their lifestyle conflicts with my religious practice. So to have the evolved conversation with that person, it's not about them sacrificing anything. No one's telling you to change your religion or change your beliefs. We're saying, again, if you are in this profession to be in service and of service to others, to render care, to render assistance, then understanding everything about your patient, including their sexual orientation, their gender identity, understanding and respecting that is just another tool in your toolkit that helps you render better care. And so getting them to understand and evolve their thinking around communities. You don't have to agree with every person who comes before you. You don't have to agree with their lifestyles. You don't have to agree. People can be violent. They can be destructive. They can abuse substances. You don't have to agree or condone any of it, but you have to understand it. And you have to understand it as it relates to your ability to render care and build trust with that patient. And so I think for us, we start from that position. And a lot of the work we do isn't just the formulaic academic, training per se. We have conversations. We try to create spaces where people can have some open dialogue. We try to expose people, to immerse someone in an experiential situation, whether it starts in medical school or during a residency or ultimately in the hospital, where you have to come in contact with different people, that you're up close and personal. We started doing that with medical students and bringing them over to local housing projects in partnership with Dr. Tracy Gardner, who I'm sure many of you know well. Exposing medical students, taking them outside of the classroom. Practicing medicine is so much more than, a person is not a walking diagnosis. There's so much more than that. You have to have a comfort level in order to build trust with them. And so we expose and start stripping away and having some of those difficult conversations. You can't run from it. This month, we're looking at the issue of the lack of Black men in medicine by looking at a brilliant documentary, Black Men in White Coats. And so again, there might be some people who are uncomfortable with those kinds of conversations. We're not running from them. We're saying, we know this is an issue even in our system. So let's talk about it. Let's talk about what our responsibility is to grow a more diverse workforce. And if looking and having these conversations is a way to start that and broach that topic with some people that will ultimately get to the beyond the conduct to hearts and minds, then that's exactly what we're moving towards. Because again, at the end of the day, this is not like banking, and I'm not, no offense to anyone who's in finance, but you've got real lives. There are real consequences to the decisions that you make. Again, I look at my son when he's home from college now, and he always, Mom, why are you staring at me? You're so strange. Because I understand what I almost lost. That was the real consequence I would have suffered. So I think to continue to drive that point home, you do it by getting up close and personal and grassroots with the communities that we serve. And it's not always going to be pretty.
Well, let me tell you, 2020 has been revelatory, right? And there is an urgency for things to change and change now. We don't have time, you know, while people are still dying, you know, to keep working on it. So the programs that you just delineated, should they be mandatory? And should we tie reimbursement to these outcomes that are disparate based on race and ethnicity? What is your opinion on that?
Absolutely should be mandatory, but more importantly, you know, I tend to believe the argument you make for why diversity, inclusion, equity, access, increased opportunities, creating welcoming, inclusive environments, the argument you make is tying it back to healthcare itself. So I don't talk about this work in altruistic terms. I'm not going to talk to you about feeling good and everyone's happy. I'm going to talk to you about how doing this work and doing it well will help us render better patient care. That will help drive the patient satisfaction rates, which we know are tied to reimbursement rates.
That's a good one.
Hospitals like bottom line, right? I'm going to make the business argument for you as to why you should care about this work too. And so when we talk about making it mandatory, this should be built into every strategic plan of a hospital system. It should be tied and aligned with the organization's mission. It should support the values. It should help drive the vision. It should be at board level governance is what we have. Our board actually created a diversity committee to look at these issues, and every several times a year I have to go before them. You need that level of commitment. You need hospitals and healthcare organizations to create more positions like mine, senior leadership positions, with someone with enough heft to actually impact and influence some of what's going on. Otherwise, this work stays on the margins. And again, it's too important for us not to get this right. And so I think the mandatory nature of it, I think you're going to need some of those outside influences like the social justice movement that happened this year, like COVID-19 and conversations about health disparities. All of that starts exerting pressure on hospital and healthcare systems, and people need to start holding them accountable. What are you doing? What are you willing to change? What are you willing to institutionalize and implement? And what are you doing not just now, but in perpetuity? What are you going to be doing 5 years from now, 10 years? Those are the conversations we should be having about accountability.
Wonderful. Thank you.
I wanted to add, if I can.
Absolutely.
That, you know, when you commit to working in the public sector, you have a duty to do no harm, right? So that means that, yes, these things need to be mandatory. And even before we get to a place where we're mandating these in, you know, medical industrial complexes, during the training, during the education process, these need to be the norms and the standards. How do you relate to the people and the communities that you're going to serve? I know in other countries, they said they've had great success with midwives actually training the physicians, right? Because then they get an idea of this midwifery model of care and individualized care. In terms of, you know, compensating or rewarding, you know, hospitals when they do this, I'm like, this should be the basics. Like this is not something that we should be getting a pat on the back for treating everybody, you know, in an equitable way, right? We need to get to a place where we're putting people over profit, and that's something that we haven't done. So yes, you know, if you're getting great outcomes, like you said, the bottom line is going to be impacted, and we know the outcomes are going to improve when you are treating each person on an individualized basis. You know, Mecca, you shared, you know, personal story earlier, and I wanted to share briefly. When I had my second child in a hospital setting, they brought me the wrong baby to breastfeed, which started a whole fiasco. But when I asked to be early discharged, right, um, they made a big fuss about the hepatitis B shot and all this. And at that point, I just did not feel safe with this hospital giving my son anything because you brought me the wrong baby. So the trust is shattered at this point.
Mhm.
And I remember they told me that I had to speak to the pediatrician on staff first in order to be discharged. And, he came in, white male, and said, what is this nonsense that you're not going to give your child the hepatitis B shot? And I said, well, I'm not saying that I'm not. I'm saying that I'm not going to have your staff administer it. I said, and, I know about passive immunity. I'm going to be breastfeeding. I've had the hepatitis B shot. My baby will get the antibodies through me. And he looked me straight in my face and said, you people always say you're going to breastfeed and a week later you're not breastfeeding. That stuck with me because that let me know this is the main pediatrician at this hospital. That's how he views every woman of color who comes in here, which means that impacts the way in which your lactation staff do or don't give lactation support, which is why we have a lower breastfeeding initiation and duration rate, which is why we have a higher maternal mortality morbidity rate for babies born to Black mothers. So when you have, a whole staff of people that have a preconceived idea about an individual group or groups of people, that impacts the type of care that they get, that impacts the type of resources that you give, and the amount of time that you're going to divest to these people if you're thinking of them as you people, right? Or you're just thinking that it's a waste of time to even instruct them on breastfeeding. And I had to say to him, I breastfed my older child for 2.5 years. Thank you very much. I said, so what does that mean? And he was like, oh, and then he tried to backpedal. And I'm like, the damage is done at this point. Right. So these type of trainings should be mandatory. It should also come from the place when you're first getting education. And there are conversations that need to be had even in high schools, right? When we're introducing people to different fields that they might want to go into, birth work and, health fields. These are conversations that need to be had at that stage before we've already started having these negative ideas planted in our heads that are harder to undo.
I'm sorry, can I just?
Absolutely.
Because it's important and it's tied to research and it's everything Nubia just shared. Also, the experience itself. So someone thinks that you had this one experience, but that shouldn't color your feeling about healthcare. That's exactly what happens.
Right.
People don't realize the nature of that experience. And when they've done studies, it is rare that patients complain about the actual care they received. It's most people, they go for heart surgery, they have a successful heart surgery. What patients complain about in healthcare is the experience. Now, whether or not you respected my food choices, whether you respected my choice to hold off on getting a shot or breastfeeding information, it's whether you looked me in the eye when you walked into the room, it's the time you spent, it's the tone of voice you used, where you condescended. All that experiential nature, again, it either builds trust or it destroys trust. And unfortunately, the trust that gets destroyed is in the communities that need it the most.
Yes. Yes. And I have to interject, that's what's happening with the vaccine, right? The Black and Brown community are the predominant cohort being affected, and the hesitancy and just distrust, lies within that community as well. I want to sort of repeat something I heard in one of the seminars that I attended in the last 2 weeks. It's not, for Black and Brown communities to start trusting. It's for healthcare institutions to become more trustworthy. And that stuck with me because, again, it's just sort of this reversing of the narrative around, whose fault it is. It's your fault for not trusting me. And I think part of, what we need to take away from this conversation is that we need to sort of backpedal from that attitude, because that in and of itself, is steeped with racism. We're not a monolithic group, right? And if you talk to a patient and your interaction, begins with that sort of stereotype, then you're already in trouble. So I need to leave. I am getting pinged. It's 8:10. I need to leave a few minutes for questions. I want to thank you for your information, for bringing, with you your experience, and for being so lively and forthright and transparent. Do we have any questions? I need to pay attention to the chat, and then we will go from there. If we don't, we're going to keep going. We're going to keep talking about this fantastic conversation. Fantastic in the sense of how important it is and how happy I am to have voices with some expertise, in different niches that sort of impact. So we don't have any questions for now. So I'm going to keep going because I have some other questions that I've been wanting to ask. So Mecca, I'm picking on you a little bit, but I want to stick with the sort of the systemic racism and the issues therein for a little bit. And I don't know if you can speak on this with any sense of information, but electronic medical records and just electronic, just sort of moving medicine away from the individual physician and moving it to standardized program, just an overall. Is that something that hospitals are moving to? Doctors don't like it because it removes their autonomy and their interpretation of what they think the patient wants and needs. But it has been touted as a way to standardize and normalize care, such that no matter where you are, if you have a heart attack or if you have, a partial placental abruption, you're being offered the same options. Any comments around that? And then Nubi, I want you to chime in on what you think about that as well.
So, and I think it's the bigger issue of our ability through better electronic collection of data and information, including information about, race, ethnicity, language, sexual orientation, et cetera, capturing that information and our ability to leverage and look and do research and analysis on the data that we're capturing and to cut it and to stratify it. That's the important part. You can't identify health disparities without the data. You can't get the data unless you're accurately capturing. And again, our system, we just went through a major overhaul with our system and with the organization, the company that was doing it. We made sure we built in those components so we can track all of that demographic information that's going to become so useful to us. And even, everything from training our registration staff about the cultural intelligence, about asking and eliciting that information. Why am I asking you about your sexual orientation and your gender identity? Well, because it goes to your care. We want to render the best care to you. Why am I asking Miss Santana whether you are a Black woman? I
want to interject. People are afraid to self-identify though, because they're afraid that this is going to be used against them. So how do we embrace that with respect and understanding while, sort of having sort of ready messages to sort of counteract that type of thinking?
Well, I think it's everything. It's not just training your registration staff. It's also creating a climate where people feel comfortable. If I walk into a hospital, I want to see images that reflect me. I want to see language that reflects me. That way, when I'm sitting with the registration staff and they say to me, there's a set of questions we need to ask to get your demographic information because it ensures that we render the best care that is individualized, patient-centered to you. Well, then I'm saying to myself, I'm somewhere where I feel welcome, I feel safe. I feel like there's a real investment in getting that information from me. And so I'm going to be willing to share. And if I'm not willing to share, I know they'll respect that. But if I walk into an environment and the way I was treated was rude, I speak another language and there was no one there to help me kind of navigate, and then I sit down and someone starts peppering me with these questions, well, then to your point, you haven't done the requisite groundwork for me to feel comfortable sharing that. And again, when we're not getting that data about who we're seeing, what we're seeing, the trends, we can't identify those disparities. And then we can't target resources to address those same disparities. It's like the census. There's a reason why you want to make sure you're counting everyone so that all voices are heard. So I think the more we do from a technology standpoint, the better off systems will be for it, because data is a big part of this conversation.
Right, it is, and I'm a culprit. I'm always afraid to fill in the box that says Black, because I'm afraid, and I'm a physician, and I'm educated and I understand what that means. But as a human being, I still don't want to deal with the prejudice that will come when someone looks at that box and sees it in Black. So it's definitely a real thing. But I want to I say that to acknowledge the concern, but I also want to really sort of reiterate and spotlight your comments that it is important. We're not going to be able to get to the root of the problem and find people accountable unless we understand what's happening, and only aggregate data can help us do that. Nubia, did you want to chime in on this topic?
Yeah, sure. So I think there are benefits to, electronic health records, especially when you have the component of a patient portal, right? So that they have access to, their visits, they can kind of look through their results, they can ask questions, you can interface, with your provider. I think that's crucial, especially when, if someone's seeking to switch care from one provider to another, and then there's a lag time in getting their records, and especially with midwifery, and especially if you're wanting to switch to a home birth, right? We need to know that you are having a healthy pregnancy. There are no underlying issues. So when someone has that access and they're readily able to share, those records, that makes it more of a seamless, transition. I will say I'm also kind of wary of moving more towards technology and away from interpersonal, interactions with clients, especially when we're talking about prenatal care, because for midwifery, it is about, laying on of hands, right? It is about actually asking this person and looking at their facial expressions. So, in hospital settings, sometimes there's this big, screen with all of the, what's happening in each room. And that's what people are looking at, as opposed to being in each room and asking the person, how are they feeling? And that if the monitor says everything okay, that everything is okay, that means that is so. But you have somebody in the room that's saying something doesn't feel right, and you say, oh no, well, the monitor says you're fine, right? So, we want to have a healthy balance of using technology, but also, at the forefront, putting what is the patient saying, what is the client saying, what is the mother saying, what is the birthing person saying, because that should, override everything else.
But wait, are you saying that we should treat the patient and not the machines? Is that what you're saying?
Yes, I know, right?
Or treat the patient and not the disease, right? I mean,
right.
That's the point.
Right. Yes. And especially, during the whole, pandemic, where we began to switch to telehealth, for safety and social distancing, I think it was easier for some midwives and home birth midwives specifically to make that switch, because we're always incorporating our clients into their care. So they know how to palpate their bellies. They know how to measure. They know what that means. They know what, normal blood pressure is, and when to kind of notify us if their blood pressure is out of range. So it was an easier transition for us. But if you've been going to a provider where, it's okay, we do all the vitals, you're in and out, and now we ask you, oh, take your own blood pressure, let us know if you're having a warning sign. People are like, well, what warning signs? What blood pressure is, too high? What pulse is they don't know. So it's good to get into that space of making sure that the people that you're serving have a basic knowledge about their own care and when something doesn't feel right. And even if they don't have an understanding of that, if they're saying something is not right, again, definitely from Mecca's story, right? We need to listen, to them. Right. So yes, we can use, technology and, all of these things and tools that we have, but we also have to balance that with individualized care.
Okay, thank you both for your input on that. And I'm just going to sort of point out, some of the key themes. We started the top of this conversation with the stats that Black women are 2 to 3 times more likely to have adverse outcome. And this is consistent or persists, even if you're not talking about women in a certain socioeconomic category. So we're really just talking about racism. I'm just going to say it and put it out there. So in addition to that, and I'm tying in a question that I just got, in addition to that, if you're an older woman, your risk actually increases. And so the question from the audience was, what resources are there, for people like me who wanted to sort of wait till they're older to have children? My advice as a singular obstetrician is to make an appointment. This is, another place where it's all about being educated and being empowered. There is such a thing as a pre-conception counseling visit. You want your care to be individualized. It's great to get information from the internet. You know, we've talked about some of the things that you need to be mindful of in terms of being healthy physically and mentally before you begin the pregnancy. But the doctor needs to know about your family history, you know, in terms of heart disease, diabetes, any sort of genetic problems or histories that they need to sort of screen for. There are tests that are new, and I would say within the last 5 to 7 years, that are specific to the individual woman with respect to screening for aneuploidy, and that we're talking about babies who have Down syndrome or something like that. So my advice to the person who submitted this question, empower yourself. Make an appointment to sit down and have your questions answered. Like, what do you need to know? What tests are available? And what do you need to start doing before getting pregnant? That's what I would do. Newbie, I'm going to give you a chance to chime in on that if you have something to add.
Yeah, advanced maternal age and geriatric pregnancy and all these things. I say
I am a geriatric mother. I'm proud, right?
Right.
I'm geriatric and I'm proud. How about that?
Right. While we do know that there is a higher incidence of, risks the older that you get, if you were 34, yesterday, as soon as you turn 35, it doesn't magically mean that all of a sudden you're at, a higher risk. So, as you said, having, kind of getting a baseline for where am I, what's my optimal health like? All of these things, that's important for anybody, I think, but especially as we get, older. And many people, have waited because they want to have their careers solidified. They want to, be in a good, space in terms of, housing and all these other things, education. So, but we also see that people are having babies later in life. So it's becoming a little bit more normalized. But for anybody, I think like you said, it's important to know where you are and know what, health challenges, if any, are present. How can you address those? And preconception, as we were talking about before, is so important. So I agree with, what you said,
right.
Julia.
And I just want to add that carving out the risk of aneuploidy, and that's having a baby where so the chromosomes aren't sort of normal. Barring that, there are older women who have more, I don't want to say successful, but have pregnancies that are less eventful, if you will, than mothers who are younger because of that health status. This is America. We have a 60% of our population are either in the overweight or obese category. And that's irrespective of body type. That's the data. And as we get older, we necessarily succumb to more things like diabetes and hypertension, and obesity in and of itself is a risk factor for pregnancy, right? So, these are the things that I would really focus on. The genetic piece, you can't necessarily control that, but you can control your baseline health status before you get pregnant. And again, I would highly recommend having a conversation. Don't be afraid. Everybody else is doing this. They will come in and they want to talk and they have a pen and a notepad. You can do that too, right? I'm bumping up against time. Let me just make sure we don't have any more questions coming in. Let me just check. Ingrid here is manning the chat box for me. So let's see if she has anything for me. So I'm going to
womaning, Dr. Nevins. She's womaning.
She's womaning?
Womaning the chat.
Voice.
She's womaning. Okay, sorry. Thank you. Okay, thank you for that correction. Thank you. Yes. All righty. All right. So I'm going to close us out. I'm going to just start by having some last final remarks from both of our fantastic candidates, or panelists rather. Nubia, if I can start with you.
Sure. Yeah. So I just wanted to say, I think this was a really great conversation. And I want to implore people to not just think about the stats, right? Not just think about, quantitative data, but also qualitative data, right? And what are the people that you're serving? What are your family members, friends, loved ones saying about their experiences? That's important. And I know we talked a little bit about, 2 to 3 times more likely, but because we're here in New York, I just want to highlight that in New York, Black women are 8 to 12 times more likely to die. And college educated Black women are 5.2 times more likely. So I want to kind of allow everybody to sit with that and really think about what's the why behind that, right? And for me, especially when I think about the stat for college educated Black women, it makes me question, what are we trying to silence? What are we trying to, stop, people from putting out there? What information are we trying to kind of bury? And especially with the stat of 8 to 12 times more likely specific to New York, it makes me think about some of the barriers to midwifery care here in New York. We are one of the only states where CPM, certified professional midwives, are not legalized to practice. And we also have an intentional suppression of midwives of color. The profession right now is 95 to 97% white. So these are some things that we need to have a conversation about. We need to discuss. We need to create more access and support for student midwives of color, aspiring midwives of color, and normalize these conversations again. When we have career days, at high schools, talk about midwifery as a pathway, talk about, obstetrics and gynecology, so that when we are serving communities, we do have providers that reflect the communities in which we're serving.
Yes. And it's very important because in terms of that level of comfort and trust, it does matter. It does matter. And I'm hoping that there will be a time when it won't, right? When we can walk into an institution of care and know that we're being treated fairly and as human beings.
Right.
And simply with that level of empathy.
Yes. And it matters because if I know what it's like to be a victim of somebody having a preconceived idea about me, I am then not going to inflict that on somebody else because I know what that feels like, right? So that's why it's important. I mean, there's a myriad of reasons of why it's important, but that's one of the key ones, that we're not going to continue to inflict something that we know is harmful because we've personally experienced it ourselves.
Exactly. We have 2 minutes. So Mecca, I'm going to have you just give me some last closing remarks, and then I'm going to close out this event.
So sure, I think I'll end by just sharing a thought, and I don't bring it up when I talk about the story of my son because I tend to get emotional about it, but a part that I left out is when I was sitting in that room waiting for the doctor to come back, I was talking in my own head and talking to my son, and I was saying, you know what, like, I'm gonna fight for you. I don't care if no one else does, like, mommy's going to fight for you in this moment. And I say that and share the importance of the fight around these issues, that these are issues worth fighting for, because again, people are dying, people are suffering. And so I'm grateful to be part of an organization that fights for these issues. I'm grateful to serve on a panel where we talk about the importance of the good fight here. I'm grateful to have met and heard from Nubia, who the only other person in my almost 50 years who shares my middle name, Earth. So I think that's a sign that we are sisters in spirit. But this is worth fighting for. And so I just encourage those out there, keep pushing, keep fighting. It's the good fight. It's not always easy, but it's always worth it. And so I thank you for the opportunity to share tonight.
I love that. I'm going to borrow that. This is worth fighting for. So I want to thank the Westchester Women's Advisory Board for putting this together, for reaching out to Mecca and Nubia and myself to have this conversation. I want to make sure I acknowledge George Latimer, Nancy Barr, Terry Clements, and Vivian DeCohen, and of course, Senator Gillibrand for the words that was spoken on her behalf. I want to thank all the participants for showing up. I hope you will leave with more information, that you will leave empowered, and that you will be able to go out and disseminate some of the information that you learned from this conference this evening. Thank you very much.